while everyone's coming up. This is a question more for Julie. We haven't heard much about viruses and their role in gastric cancer, and there's obviously a role for Epstein-Barr virus. Could you comment on what role you think viruses play in gastric cancer?
So I think you might want to ask about other infections in general, not just viruses, but other bacteria as well. And I think there is pretty clear data that Epstein-Barr virus is associated with gastric cancer, and there's mechanistic, I showed you on that, the Cancer Atlas, that there are clear different genetic changes in EBV-related cancers than in other cancers. I actually haven't looked recently about what proportion of gastric cancers are related to EBV, and so I can't really comment on how many there are, but I'm pretty confident that EBV is a risk factor for gastric cancer. There's also questions about sort of the gastric microbiome, which we used to think was non-existent, but does exist, and may particularly exist in things like atrophic gastritis, where you may be losing your acid in your stomach, and there are other organisms there. So I think there's still a lot of questions about whether there are other organisms that contribute to the inflammation and may contribute to gastric cancer overall. But I don't feel like I'm really expert on EBV, but I think the data are pretty convincing that EBV has a role in some gastric cancers. But I'd be very curious if somebody in the audience who's more expert on this might have further comments about it that I don't have.
That's not going to be me. Michelle Kim from the Cleveland Clinic. Thank you so much for all of your talks. Several of the speakers today have spoken about the importance of a quality exam and perhaps the implications of what we might be missing. So I wanted to ask you two things, because I think you have clearly an audience of the converted, I think, in this room. My two questions are, first, what do you think we might be missing on our current exams as we're doing it? And the second is, what do you think are the barriers to adoption of being able to do these quality exams? Is it time and productivity pressures? Is it culture? Is it what is it? Sorry, this is our two endoscopists on the panel. Thank you.
I think this is very important and very complex to address. My residents are not even familiar with what MVI is. And as we learned today, MVI is instrumental for intestinal metaplasia diagnosis, and then sampling biopsies to confirm intestinal metaplasia in our patients, and then put the proper follow-up surveillance and ultimately to prevent and get to early detection of gastric cancer. But I don't know if it's cultural. I know what I trained in Japan and lived in Japan for years, and everybody use MVI on a daily basis. Been in Colombia, South America, working for years as well, and there is certainly more people getting used to that. But I think the reasons is a multifactorial, complex process. Certainly, there is a lot of room for improvement regarding diagnosis, starting with mucosa cleaning, let's say, taking enough time to perform a systematic evaluation of the stomach. But culturally here in the U.S., now that I'm based in Florida, I'm seeing my fellows doing a very, very, different exam that it's been practiced in Colombia and in Japan. Robert, I don't know if you want to add.
No, I think that I agree with everything you just said, and I think there just isn't maybe that critical mass yet of endoscopists in the U.S. who are interested in this topic, who are trained in this topic, who can teach their fellows how to do it. And so, I think this is where there's a great role for the societies, our professional societies, the ASGE, the ACG. So I think, some kind of guidance for fellows on what constitutes a high quality endoscopic exam, what constitutes adequate mapping examination for intestinal metaplasia. We need that guidance until there is a critical mass of endoscopists who can teach the next generation.
want to add also that even Europe, I will put Europe in the same bucket because, you know, that image that I demonstrated, the upper cardia, that was actually not intestinal metaplasia, was originally published as intestinal metaplasia, an endoscopy journal. So there is a lot of to be done, and I think this is one of the purposes of being here, all of us trying to find, you know, a light at the end of the tunnel regarding quality of GI. I think
Thank you all
Oh,
for
go
your
ahead.
presentations. In colonoscopy, there have been several randomized controlled studies showing the benefit of using AI on the imaging. Has that been implicated in upper endoscopy to identify lesions that may have been missed by the endoscopist?
So there's a little bit of, there's some interesting work out of Japan on this topic, actually, which we're going to hear about later in this summit. So I think that currently there is data to suggest that AI can certainly enhance the characterization and detection of cancers, so of early cancers. But right now, as far as I'm aware, there haven't been any good studies to show that AI can enhance the detection of precancerous lesions like metaplasia yet. But I think a lot of that research is in the pipeline.
Meaning colon, they're picking up the adenomas, so that's a potential precancer. Maybe too effectively, because a recent study came out this week showing a lot of benign lesions were detected. So I think it has to be investigated.
Mm-hmm.
I think we have time for maybe for one more question.
Yeah, I think that this has been proven and is in the market now. I mean, artificial intelligence software for polyps in the colon, and also as recently developed for gastric cancer. Not as far as I know for atrophic gastritis and intestinal metaplasia, but it's just something that is coming up, I think, in the near future. My point here is that if we don't steer the tip of the scope at the place the artificial intelligence should identify the lesions when they are present, I think it is a waste of resources and time. So again, WHO as a World Endoscopy Organization is very much driven to educate people in a very basic of performing a complete and sequential and systematic exam with clean mucosa before coming up into these high technologies, costly devices, because it will be waste of resources again. So at the time, technology is overwhelming and the market is coming to us. We need also to move in the basic arena to perform a high quality exam. Otherwise, it should be still the unbalance of technology and low numbers in terms of survival and early detection.
So actually, I was going to ask AI question also because I'm an AI person, not an MD here. But I'm glad he jumped before me. So I just want to follow up on this. I think it's pretty obvious you have image detection that AI can help here. But I want to go beyond that because Dr. Huang mentioned individualization. There are a lot of other places where AI can potentially help. Has the community be thinking about going beyond image processing and much broader application of AI?
That's a tough question. Certainly, it trespassing the frontiers of my understanding. I don't think that at present. Do you have any ideas about? Beyond artificial intelligence, what is in your mind?
Oh, because I mentioned, I heard, even with talking about this particular conference, precision medicine and the Asian community, but each of us is actually pretty unique, right? So can we go even beyond the gender and the ethnicity and going beyond individually? Can AI help you over there?
In terms of cancer, I just tend to imagine now immunotherapy. If you're gonna go beyond the frontiers of the summit, I just can think on immunotherapy for targeting cancer. That is something that is, widely applied now, especially for colon cancer. There is a lot of research going on. But I don't know if that makes sense regarding that question.
I mean, I think I have an idea here. So this is totally different from immunotherapy and image processing, but I was talking about ICD codes for detecting IM. It turns out those codes are not used very often, and so right now a lot of the time, if you need to find patients with a history of H. pylori infection, you have to look at the pathology records, and the ICD codes have very poor performance characteristics. So I know a lot of groups are trying to develop natural language processing tools to, say, mine through the pathology records a lot more quickly, and create a structured data set using NLP tools. So that would be an example of where AI could enhance scientific discovery.
Okay, can follow up. Okay.
Yeah.
We have one last question.
Thank you very much also for all the presentations, and I like the combination from current data with the history. And actually, I think we can really learn from history also here, because I totally support the idea that the first step to make is to actually enhance the endoscopic recognition. I think we all agree that nowadays everybody has wonderful equipment, but if you don't know what you see, you don't know what you have to look for. Now, this is what we learned, and look at Julie, with Helicobacter, after the original paper, suddenly all pathologists recognized that what they had been seeing already for decades was there. And as endoscopists over the last years, we've learned it, for instance, in recognition of eosinophilic esophagitis, serrated adenomas, and so on and so on. So my question is, what can we learn from this past in terms of actually explaining to people what to look for, because it's very easy.
Again, that's a tough question. I think that we can start recognizing normal mucosa. And then we can add from that point abnormalities. Just imagine teaching my young fellows about that. A little bit before that, looking at the entire stomach lining without mucus and saliva, I think is fundamental. Otherwise, looking at a dirty stomach, I think doesn't make any sense too. So I think that's what comes to my mind. Yeah, and then I think MVI or VLI or whatever technology is available, including Pentax also. I mean, regardless the instruments we have in our hands, the mindset for looking at abnormalities and then take biopsies, I think, will determine how the quality of endoscopy will improve or not.
I think in the US, I think we have a culture of doing quick endoscopies, like 3 minutes or even 1 minute. I think this is very common. There is a really widespread under-recognition, under-appreciation of importance precancerous lesions in the stomach. So we don't really do a good job at all. So I ask around the DDW, even among my colleagues, do you use NBI? I think 80%, 90% of the time, the answer is no. So I think we really need to change our culture to do a careful exam and at the minimum, because otherwise you cannot see anything that's dangerous or potentially dangerous. I think the upcoming ASG and ACG guideline in terms of quality gonna will help move the needle forward, so we can change our culture and do a good job before even using AI, because that's the next steps.
Yeah, I would echo those remarks. I'm glad Doug Morgan is here, and I think that the bottom line that I hear, kind of the resounding, overwhelming message is that we need better quality indicators for upper endoscopy, and we're still lacking them. Fortunately, he's going to be talking about the updates. I've reviewed them. They're a great step, but we still have a ways to go. So with that, I'd like to thank the speakers and the moderators for this session.